Hello, my name is Jia Lee, and I am a current sophomore at Pinewood School. Today I'll be discussing the outcomes of chimeric antigen receptor T cell therapy treatments in multiple myeloma. Essentially, this therapy treatment has the most potential as a promising treatment for multiple myeloma so far. There has been results of high response rates, which I'll be further talking about later on. Here is some background information on multiple myeloma. What exactly is it? Well, it's a type of bone marrow cancer and is considered as the second most common hematologic cancer. It is chronic and relapsing, meaning that patients experience periods of response that relapse over time. It is found in plasma cells, making the plasma cells grow uncontrollably, leading them to crowd out the healthy blood-forming cells. Plasma cells are the white blood cells that produce antibodies, also known as immunoglobulins. They are crucial for the immune system and defend the body against pathogens. Multiple myeloma also instigates the production of M proteins, which are a type of abnormal antibody that affects the bloodstream. Like I mentioned, this results in the disruption of the blood cell production. Some consequences the patient can experience are bone pain, renal failure, a condition where the kidneys stop working properly, anemia, and hyperglycemia, a condition in which the calcium level in the blood becomes too high. I will go into further detail later. As of right now, multiple myeloma is considered incurable. Now, figure 1 on the right shows a microscopic close-up of these cells from the bone marrow. As I noted, the deep purple colored cells that look larger and have an eccentric nuclei are the myeloma cells. Also, the annual incidence for multiple myeloma is 4.5 to 6 cases per 100,000 individuals. There are four potential treatment options for multiple myeloma: chemotherapy, stem cell transplantation, plasmapheresis, and chimeric antigen receptor T cell therapy. First, chemotherapy works by using strong drugs to target and disrupt the cancer cells dividing. This is called systemic therapy, meaning that the drugs circulate inside the blood to attack the cancer cells. Autologous and allogenic stem cell transplantation works by using the chemotherapy to kill the cancer cells, but then afterwards the stem cells are used to help rebuild the blood system. The only difference between the two is the source of the stem cells, whether it came from a patient or from a donor. Next, plasmapheresis works by removing the plasma, also the harmful M proteins, from the blood. After the separated blood is infused back into the patient, a replacement fluid or donor plasma is also mixed in. This can help stabilize the kidney function. However, this treatment does not directly kill myeloma cells. And then for chimeric antigen receptor T cell therapy, I will be talking about it more further on. Also, multiple myeloma is associated with the CRAB criteria, which are a set of symptoms that are essentially used to diagnose active multiple myeloma. I briefly listed them before, but here it is again. C is for calcium, R is for renal dysfunction slash insufficiency, A is for anemia, and B is for bone disease. All of these are potential and common symptoms for multiple myeloma. For example, hyperglycemia happens when levels above the upper limit occur, so for example, 11. This leads to bone weakening and kidney stones in the patient and can also be a sign of multiple myeloma. The diagram on the right is figure 2 explaining further on the CRAB criteria. For my methods, I conducted my research by following the PRISMA guidelines. I used PubMed and its advanced search queries to find my sources. My key search terms were multiple myeloma, cell therapy, life, effects, and patient. As a result, I excluded 24 articles and was left with 6. My exclusion criteria was whether or not the study concluded the effects of treatment and whether the patient resulted in a better quality of life, and if the source was a systematic or literature review. Before we dive into the studies I analyzed, here is a rundown of how CAR T cell therapy works exactly. The treatment works by using engineered T cells to target tumor-located regions. First, the process starts by collecting T cells from the patient's blood and then using a machine to separate the T cells from the rest of the blood. This is then returned back into the person. Afterwards, the collected T cell samples are sent to a lab in which they are genetically engineered and modified that makes the T cells to recognize a specific protein on cancer cells. After the lab further multiplies those cells into a quantity in which the treatment deems effective, it is infused back into the patient. However, within this CAR T cell therapy, idacaptogene viclocel is the multiple myeloma specific CAR T cell therapy type. The T cells target B cell maturation antigens, also known as BCMA, which are the proteins on the malignant plasma cells. When those B cells become cancerous, that is when multiple myeloma emerges. In a healthy scenario, those B cells turn into plasma cells, which essentially become antibodies that target infections. However, when a patient has multiple myeloma, the B cell evolution goes wrong, leading to an uncontrollable plasma cell growth. The first study I reviewed was by Delforge and others in 2023. There were 45 participants out of 131 invited individuals. Around half were male, which is around 56%, and the mean age was 63.5 years. The interviews were conducted 6 to 24 months after the infusion process. Minimum side effects were reported from 35 individuals, which is around 51%, and 93% experienced the efficacy benefit. The chart on the right, figure 3, shows how the multiple myeloma patients felt about the idacaptogene viclocel treatment at 6 months, 9 to 12 months, and 18 to 24 months after the infusion. It categorizes the reports into advantages and disadvantages. This figure essentially concludes that in the early months of the treatment, they felt a strong remission, improvement in quality of their life, and the side effects on whether they're resolved or manageable. At 9 to 12 months, that is when the patients feel the most benefit from the treatments. However, they also feel the best balance of remission. However, at 18 to 24 months, fewer report the remission are at the best advantage, and some begin to worry about how the response didn't last long enough, which is also the biggest disadvantage. As a conclusion from this study, the idacaptogene viclocel treatment provides strong early benefits that only last initially after the infusion, but can simmer as time passes. The second clinical trial I researched was by Oswald and others in 2023 as well. 49 out of 63 approached individuals participated and went through with the trial. The median age was 66 years. The following clinical outcomes were as follows. Complete response was 38%, good and partial response came from 5%, partial response 31%, minor response 12%, and a progressive disease from 12% as well. These following results concluded that there was an increased quality of life. 57% reported a difference in physical well-being, in fact. Figure 3 on the right displays how different aspects of the patient's quality of life changed after receiving the CAR T cell therapy. The overall trend shows how CAR T cell therapy is physically tough in the beginning for like the first 1 to 2 weeks. Small declines are reported, such as fatigue. However, by 1 to 3 months after, the patients recover and often feel better than before the treatment. We can conclude that even though CAR T cell therapy is challenging at the start, it gets significantly better months after the treatment. As a result, these findings tell us how we need to further research and recognize the potential of CAR T cell therapy and other treatments. More research is necessary to fill in these gaps, which contain inconsistencies such as disease heterogeneity. Multiple myeloma is highly heterogeneous and can have different results on everyone. This is important because the incidence for multiple myeloma is rising, essentially posing a threat to the older population. As time passes, the myeloma cells are becoming more resistant to some of the drugs, the few treatment options we have. Here are my references. And that's it. Thank you.